A bi-hormonal pump that uses glucagon and insulin for glucose control is one step closer to reality. Beta Bionics, the makers of the iLet bionic pancreas, is working toward a dual hormone model and has joined forces with Xeris, who will be providing the glucagon component for the device. Welcome to the show. I'm Justin. I have type 1 diabetes, and on here I talk all things diabetes tech, news, and management with educators, tech leaders, and those thriving with diabetes. I spoke with Beta Bionics founder and executive chairman Ed Damiano about the journey so far for the bi-hormonal algorithm and device. He took me through the history of the algorithm and the iterations of testing, the pros of using insulin and glucagon and its better results, what it's like using it, and what is left to get it to consumers. Just a year ago, Beta Bionics released the iLet bionic pancreas. This pump allows the user to simply choose meal sizes for a bolus without the need to carb count. I've got an episode with the CEO on my podcast going all into that pump, and I've got a demo of the pump itself on my YouTube channel, so go check those out if you haven't already. If you'd like a video diving deeper into the history of Beta Bionics, seeing what all of the original devices looked like, even some of these really old ones and bulky ones that we talk about in this interview, give this video a like. I think it could be an awesome deep dive, investigative journalism-y type video, so let me know in the comments as well if you want to see that. Keep in mind that anything you hear on this podcast or any content on any of my platforms is not medical advice. Always consult with a physician before making changes to your healthcare. Today's episode is sponsored by T1D Exchange. You can directly make an impact on diabetes healthcare, treatments, and technology by participating in the T1D Exchange registry. It starts with a simple survey about your life with T1D, and it only takes about 15 minutes. After that, you'll have a personal portal with ongoing T1D study and survey opportunities. Plus, some of these studies even offer compensation. Signing up with the link in the show notes helps support my channel, and it allows me to continue putting out free content. You can sign up at t1dexchange.org/diabetic or click that link in today's show notes. Ed, I'm so happy to have you here on the show. We made it. A few cancellations due to COVID. We have you outside, away from family, but it's a beautiful background. It's raining, but I'm happy to have you here.
Thanks, Justin. It's great to be here. Thanks for being patient with us. We didn't expect the curveball from the virus, but here we are. I'm on the mend.
Of course. Yeah, no problem. I'm so honored to have you on the show. I've heard about you a lot. I've listened to other podcasts you've been on in the past. So it's really cool to have you here and to talk about your bi-hormonal pump. Before we get into that, I want to just hear a little bit about you and your background. How did you get involved in working on a device like this?
Yeah, that question often comes up. So, I mean, my background was not originally in diabetes. I would have to say what I did was study mathematical biology. So I was initially a professor of biomedical engineering. My academic career started at the University of Illinois in mechanical engineering. And I was always doing mathematical biology, even back then, looking at blood flow and microcirculation, looking at blood flow in large vessels, looking at fluid structure interactions in the inner ear. And all these things we're getting at trying to understand normal, how physiology and pathophysiology of various physiological processes. And we used mathematics as the central language for doing that in physics. In 2000, I'd been at the University of Illinois for a few years. Our infant son developed type 1 diabetes. My wife, Toby's a pediatrician, and she diagnosed him at 11 months of age and had very, very little, in the way of meaningful symptoms that could really draw a layperson to, or would have drawn a layperson to a diagnosis, but she wasn't a layperson. She was a pediatrician. They did a blood sugar test, and he was 800 mg per deciliter, so 8 times the normal range. But his A1C was near normal. It was 7%, which means, in my mind, Toby got on it quickly. She used very little information to come to what was ultimately the right diagnosis and spared this guy what was, would have been a much worse DKA or simply non-survivability. He was so frail. He was 18 pounds. He'd lost 10% of his body weight. He dropped from 20 pounds to 10 pounds to 18 pounds when he got into clinic. and we got him on insulin therapy right away, obviously. Brought him out of DKA, got him into range in the pediatric intensive care unit in this little town in the middle of central Illinois. And within 24 hours, we were home living with an infant with type 1, which not a lot of people have ever had that experience, fortunately. And we got him onto an insulin pump 60 days later. So he was only on injection therapy for 2 months. And he started an insulin pump in 2000 at 13 months of age. And he's been on a pump, and when he turned 9, a sensor ever since. But the thing is that, that really was a turning point for me professionally. So I thought, what can I do? What skill sets do I have that might help people with type 1 manage their diabetes? I didn't have the skill sets to engineer a biological cure, but I thought I had some skill sets within my lab that I could use to develop algorithms that dose insulin and glucagon in people with type 1 automatically. So the idea, of course, is to say, imagine there were a sensor, which there really weren't any reliable sensors in 2000, but we saw the efforts that were going on in the industry to build sensors. And within a few days of his diagnosis, I was looking at a glucagon kit in one hand, insulin vial in another, and I said we should be using both hormones, like is used in normal physiology, and we should be infusing that with these insulin pumps, which seemed to work pretty well by the time of 2000. Hopefully, the enterprise sector, academia worked together to develop reliable sensors, continuous sensing, and you put those things together and put in the middle decision-making software that we could develop in our lab to command the insulin pump based on the sensor signal and the insulin it dosed and glucagon it dosed, and we should be able to close the loop. So I had a PhD student at the time named Firas Al-Khatib who literally just joined my lab, 3 or 5 months before David developed type 1. And he finished his master's thesis with me, and I asked him to sort of think about this project, which he really liked. And that became the sum and substance of his PhD. By 2004, I took a faculty position at Boston University, moved to Boston. Firas came with me, and then started a postdoc with me. So I would say around 2005 is when we started studying in an animal model these algorithms. And by 2008, we were doing human trials, and I collaborated with Stephen Russell. Starting in 2006, really, we began our first human trial in 2008, doing these studies in humans for, a 12-year period, 20 human trials. Over 12 years ensued from that forward.
Yeah, and I want to get into that timeline, and because I'm pretty new. I was just diagnosed 3 years ago, so I'm pretty new to the whole space. I love technology. It's how I fell into all of this. And it's funny to me how algorithms for a bi-hormonal pump began around at the same time when algorithms for just insulin were kind of really starting to pick up. And so I think most of my listeners understand what insulin is, the automated insulin delivery systems delivering insulin right now. But can you explain to everyone what they may not know about glucagon? I think a lot of people also have gotten the glucagon kit, whether you inhale it or you have to inject it to save from a life-threatening hypo or low. But what is glucagon at the root of it, and how are you trying to harness it? You kind of got into that, but
yeah, really good question. So in people without diabetes, we use insulin. Obviously, the pancreas secretes insulin into what's called the portal circulation. It's the circulation that goes right to the liver from the pancreas, and it delivers that hormone right to the liver. But it also secretes glucagon, and insulin basically is a glucose lowering hormone, right? It lowers your glucose. Glucagon, think of it as counter-regulatory. It's opposite of that effect, like a brake, an accelerator and a brake. Glucagon raises your glucose. And so if the pancreas over-secretes insulin, it can secrete glucagon to account for that. And how that works is it secretes, again, glucagon from the islets of Langerhans, which is where the insulin is secreted out of the pancreas, right into the liver circulation. The liver stores something called glycogen, and that's the substrate upon which glucagon acts. So when glucagon's delivered to the liver or secreted into the liver by the pancreas, it breaks down glycogen, which you can think of as stored sugar in your liver. It breaks the glycogen stores down and liberates glucose in the process into the blood, raises your blood sugar. It's kind of like taking a dextrose tablet from your liver, right? And so that's how normal physiology works. The liver is mediating that glycogen breakdown. Glucagon is stimulating it. The pancreas is regulating the release of it. So it's releasing insulin as your glucose levels rise. The beta cells in the pancreas are sensing your glucose and releasing insulin in response to rising blood sugar levels. And the alpha cells are releasing glucagon if your glucose is low. And what's not fully understood, if glucagon, if the alpha cells in your pancreas that secrete glucagon have a glucose sensor, or more likely they use cell-cell communication because the alpha cells that release glucagon are neighboring, co-located with the beta cells that secrete insulin. They communicate. There's cell-cell communication there. So one thought is that the alpha cells that make glucagon talk to the beta cells, and when they see the beta cells are quiet and not releasing insulin, it must mean you're kind of low. And so that's the signal for the alpha cell to release glucagon. So you can see why that is important is because in type 1 diabetes, which is an autoimmune disease, right, your T cells, your immune cells, perversely attack your beta cells that secrete insulin. That's the known mechanism. We don't understand completely why that happens, what the triggers are. Once you lose beta cell mass, you can't secrete insulin. Therein lies dysregulation in type 1 diabetes as we understand it. But because the beta cells that make insulin are gone, the alpha cells have nobody to talk to. Their big brother was taken out. So they don't know when to release glucagon. So what really happens when the T cells wipe out the beta cells is you effectively have a dual hormone insufficiency. You, in essence, lose your glucagon capability, your counter-regulatory capability. So people with type 1 are at higher risk for hypoglycemia than most people with type 2 who still have beta cells. They just don't make enough insulin because they're insulin resistant. But their alpha cells are talking to those very busy beta cells and knowing when to secrete glucagon if they ever do become low. And so they don't have nearly as much risk for hypo as type 1. So you guys really have a dual hormone insufficiency. We should be respectful of that. Human physiology has evolved to need both hormones. It's not like it's a vestigial capability. People without type 1 are secreting glucagon as our main line of defense against hypoglycemia. Why shouldn't you guys have that restored through a bionic pancreas as well? So that's where the idea came from in my mind to use both hormones in a subcutaneous fashion. And that had, a lot of people I think had thought of dual agent approaches and maybe dual hormone before I did. But this idea of using it in a mobile system that uses subcutaneous infusion, the glucagon rescue kits are intramuscular, big needle, like a harpoon. It's scary, right? This was like subcutaneous. Does it really work? So we had to start testing that first in pigs and then in humans to see if we could raise pigs' blood sugar with little tiny doses of glucagon, not the rescue dose, which is huge, but the little ones, that we're going to give with the bionic pancreas, which are non-rescue doses. They're small therapeutic doses.
Would a device like this be fully closed loop? Right now we have hybrid closed loop where the users are still needing to log carbs. They're needing to put on targets for when they're working out. Does a bi-hormonal pump take away all the user interaction when it comes to stuff like that?
Well, so I think that it takes away most of it. Certainly you can make a case for not doing even the meal announcements. So we don't log carbs with the single hormone iLet either. It is truly determining 100% of the therapeutic insulin, right? And there's no hybrid closed-loop system that does it, which is why we describe the single hormone iLet as, which is delivering insulin, as a device that is not a hybrid closed-loop system. It really isn't, because every single dose is determined autonomously by the device. All basal insulin is determined de novo by the iLet. All correction insulin is determined de novo by the iLet. And even the meal announcement doses that the iLet computes are determined by the iLet. You don't determine that dose. You just alert it to a meal and bucket it as a breakfast, lunch, or dinner that's usual, more or less than usual for me. So it's not carb counting, it's not logging carbs, and it's not titrating insulin, which hybrid closed-loop systems require people with type 1 to do. But many people still object to saying it's fully closed loop, which I fully understand, because you still do want to get some priming insulin up front, which means you do have to talk to that device and let it know a meal is coming, even though it's going to determine the dose. Well, we still do that with the bi-hormonal system because there are going to be occasions. First of all, I think it still optimizes glucose control, even with bi-hormonal, because it gets some insulin up front, and insulin is still slow. With our bi-hormonal system or single hormone, it's still a slowly absorbing drug. Glucagon is a great help, but it's still got those challenges. But the other thing about the bi-hormonal system and any of these systems, whether they're fully automated or not, they're fully automated only insofar as the CGM continues to stream data. So if the glucose monitor goes offline, which to date, we don't have CGMs that are so reliable that we can expect a signal from them every 5 minutes of every day. They go offline. They fail. And then you have periods of blackout where even a bi-hormonal bionic pancreas needs data. So in that scenario, suppose it takes you a day to get your sensor going. You still want to be able to tell it about meals. You don't want to have to learn how to carb count just for those occasions when the sensor's offline. So by using that meal announcement with the iLet, whether it's the single hormone iLet or bi-hormonal, every so often, the iLet's going to learn what the right amount of insulin is for you to treat your typical breakfast, lunch, and dinner. And so on those occasions when the sensor's offline, the iLet is able to give you meaningful and appropriate doses for breakfast, lunch, and dinner. So those learnings are needed. And the only way it can learn, even in the bi-hormonal configuration, when the sensor is on, is if you use the meal announcement every now and then. So until we have like an implantable sensor that never fails, we're always going to want to teach the iLet something about its dosing so that it can help you when the sensor's failed.
That's interesting because it's so easy for me to say, and it's true. I want a device that just does its thing, and I'm not thinking, not plugging in. I just eat whatever I want. I go on a run whenever I want, and I don't think about diabetes. I mean, that's a goal. That's my hope for technology, and I know that this is definitely one step toward that. But you're right, CGMs do fail. And you need to know how carb counting works. Your pump needs to understand the carbs that are going in, and we may not be as close to that as I'm hoping for. People always ask me, Justin, how do you keep on your diabetes technology? And it's a simple answer: Skin Grip. And that is why I partnered with them to sponsor today's episode. I use Skin Grip's adhesive patches to keep my Dexcom and Omnipod extra secure, especially during the humid summer, swimming, cardio workouts, and they are a must pack on all of my vacations. Whenever I notice my tech beginning to peel off, I throw on a Skin Grip and I'm set. And I look good doing it because they come in a bunch of different colors, and for a more subtle look, they come in skin tone and clear options. I prefer the colors though because I match them with my outfits. Skin Grip has patches for all CGMs, tubeless pumps, and infusion sets. They're latex-free, hypoallergenic, and easy to apply. As a Diabetic listener, you'll get 10% off your order. To grab some for yourself, check out that link in today's show notes or go to skingrip.com and use code Justin10. Now, back to the show. I would assume that the algorithm on a bi-hormonal pump allows for more aggressive insulin dosing. Like, is that one of the benefits here because it has that safety net?
Yeah, so there's a couple of, I see two categories of benefit that really make it a new class of device, even relative to our single hormone iLet. One is that we can be more aggressive with insulin dosing. And by aggressive, what I mean is we can shoot for a lower target, right? The device is more upset at the same, slightly, even mild hyperglycemic state than the single hormone iLet is. Just a little bit more upset, a little bit more discontent, and we'll maybe give a little bit more insulin, or maybe not more insulin, but a little bit earlier. So remember, insulin is a tricky drug because it's got such low kinetics that the timing of the dose is every bit as important as the size of it, right? And that is such a special property and an unfortunate property of insulin administration, right? So the iLet gives almost exactly the same amount of insulin in our cohort of people we studied in the single hormone pivotal trial, the bionic pancreas pivotal trial, as they were using on their own care. It didn't use a different amount. It didn't know how much they used, but it ended up using about the same for everybody on average. And yet it got much better glycemic control. So it delivered the same amount of insulin much more optimally. So the bi-hormonal system, having a lower glucose target to shoot for than we'd feel comfortable with the single hormone iLet, the bi-hormonal iLet can start insulin dosing a little earlier in the hyperglycemia than we'd be willing to with the single hormone. And that's true even for hybrid closed loop systems. If you did a hybrid closed loop bi-hormonal system, the same would be true. They could shoot for a lower target. So that's one advantage, which of course means that more people could meet goal for therapy than we're able to achieve with the insulin only iLet. And the single hormone iLet is remarkable in getting about half the cohort under goal for therapy, and the other half being much closer to goal than they were prior to using the iLet. But the bi-hormonal iLet we see from our pre-pivotal data can bring almost the whole cohort under goal for therapy. And the few that don't meet goal are nevertheless extremely close. In fact, arguably, probably all of them are under an A1C of 7.5 based on our pre-pivotal studies. So that is one of the major advantages, is bringing, more people into the fold, if you will, being able to lower the target, like you were saying, be more aggressive. Well, and that's true.
And what does that target look like? Right now we have a target. The ADA says what, 70% between 70 and 180?
Yes.
Does the bi-hormonal pump represent time in titer range, which people are talking about? Like, what is that goal range to bring people into? Yeah, is it much tighter?
I really resist the community embracing time in titer range. That is a very bad trend. It's unfortunate. There's no clinical evidence for wanting to bring people into tighter range than an A1C below 7 or 7.5%. And that typically corresponds to an average time in range of about 70%. Time in range 70 to 180, right? And introducing this concept of time in tighter range, I think, is truly burdensome to this community. You just added yet another goal for people to shoot for that's even harder. I think it's really unfortunate that that's happened. However, indeed, if you are bringing more people into time in range 70 to 180 with the bi-hormonal system, you are also bringing more people into tighter range. So that time in tighter range 70 to 120 by the very manner in which the system works, it will be bringing a greater percentage of people than a single hormone system would be into the tighter range. But I don't think we should be speaking of that range. I think it just puts more burden on people with type 1. That's the absolute opposite of what we should be achieving. And there's not good clinical evidence to support the need for that. So what happens, I think, is people who are achieving an A1C of 7%, their time in tight range is less than goal, this goal that people are talking about for time in tight range, and they feel like they are falling short. And now they have to get on an even faster moving treadmill and expose themselves to a greater risk of hypoglycemia, right? Because those people, most people, nobody's using glucagon right now to prevent hypoglycemia in a chronic way, microdose glucagon. So I think it's introducing risk into the population. It's introducing a burden, emotional burden on people. I just think it's an unfortunate thing. But yes, more people will be in the tighter range, as will more people be in the normal 70 to 180 range with the bi-hormonal system. So in essence, what we're saying is, I like to think of it as how many people in the population is the device able to bring into a time in range of 70%. And that's the way I think about all these devices. Hybrid closed-loop systems we're seeing in the wild out there, not in the pivotal trials, mind you. The pivotal trials vary so much from device to device. But in the wild, we're starting to see data of these hybrid closed-loop systems, including our own post-market data, that show that about 50% of people on these systems are achieving the goal for therapy of a time in range, 70 to 180, of 70%, and an average glucose of about 155. That's for adults. All these devices fall a little short of that in children. They are a little more challenging, and there are a little bit few of them meet range. But I like to think about it as what percentage of the population are bringing into range. And with these hybrid systems, single hormone, we're seeing about 50% are in that range. With the bi-hormonal, we can move that up to more like 90%. And remember, if you're bringing 90% in, the few that are remaining above that range are nevertheless much closer to achieving it. And with glucose control, the lower you are, the better you get in terms of outcomes, long-term outcomes. So we're bringing everybody down, or just about everybody.
I want to understand the target audience for a device like this. I think I'm a rare bird because I have pretty great control with my glucose levels. I've worked really hard to get them there. I'm using an open source platform that allows me to really not interact much with the application other than carb dosing and profiles for when I do work out. These are areas where I still have to interact with the app, but people are using the app that I'm using closed loop, not interacting with it really. But I know that a lot of people out there aren't where we're at, right? Like this is different, but we are doing this on insulin only. But like I said, our target range is 80% higher or higher. Who is this pump for, and what time in range are they? I know that there's no evidence over 70% any better, but it sounds like to me that a pump like this still could succeed in higher. So who is this for, and what are they what would they experience range wise, I guess, percentage?
Yeah. So first of all, you are a rare bird. First of all, you have a podcast talking about diabetes. Okay, let's not forget that. Okay, but before I answer that question, I didn't fulfill my obligation to you to fully answer the previous question, because remember I said there are two differentiations. One is indeed a higher time in range, more like 80% time in range on average, versus what we're seeing in the wild with these insulin-only systems, which are about 70% time in range, 65 to 70%, depending on if you're looking at kids and adult versus adults, 60 to 70%. But there is a second important distinction, which is something you've already spoken to at least 2 times in this podcast, and that's exercise, right? Our system, the iLet, hybrid closed-loop systems alike, insulin pump therapy, MDI, all therapies that use just single hormone, they require considerable consideration in advance of exercise and post-exercise. You have a lot to do there, right? You have to think about, is this an anaerobic workout that I typically do and I never see a change in, I never see a risk of hypo, but I end up going hyperglycemic during the workout, weightlifting or something. And then I've got aerobic activity where I go very, very low during the workout on one night when I'm playing with my team, practicing. And on another day, 24 hours later, the exact same basketball activity, physical activity, the same basketball game in a competition with an opposing team. And I'm stressed because of the competitive spirit. And instead of going low, like I did in practice the night before, I go high. Same physical activity, different mindset. So think about the complexity of all that you guys have to manage all the time around exercise. Well, with a bi-hormonal system, much of that is obviated by the second hormone. So what we hear from people who've used our bi-hormonal system in our clinical trials is that you can exercise more spontaneously, more vigorously, and more freely with a bi-hormonal system than any other therapy they've ever experienced. The device is there to shut off insulin, like all these single hormone systems do if it doesn't see the need for it because you're suddenly dropping, but also to bring glucagon into the equation and allow you to continue to be physically active and vigorous despite a drop in glucose. The glucagon comes in these microdoses and raises you. So it is restoring in the life of people with type 1 diabetes a greater degree of spontaneity and a greater relaxation, if you will, in engaging in exercise. That is hard to put a price tag on that. We have a statistically significant reduction in hypoglycemia with our bi-hormonal system, despite lowering mean glucose relative to our single hormone system and our standard of care population. So we don't really see in hybrid closed-loop systems or even the iLet a statistically significant reduction in hypoglycemia. We see a statistically significant reduction in hyperglycemia without increasing hypo. So that's a good value proposition, right? But with the bi-hormonal system, we see a statistically significant reduction in hyperglycemia even beyond what the single hormone systems can do, and a statistically significant reduction in hypoglycemia in our pre-pivotal trial.
Do you have a statistic, a percentage of decrease in hypos that people would see with a bi-hormonal? Is there like something to point to there?
There is, and so we see typically about half as much time below 54 and time below 70 as we would with a single hormone system or standard of care. But what we also did is we looked at the bi-hormonal system with different targets, as we talked about before. So the bi-hormonal system allows us to run safely at lower targets than our single hormone. But if ever the glucagon is unavailable because you ran out of glucagon while you're out and about, or the glucagon infusion set failed on you, right? Or you had an occlusion. And the system is aware of its inability to deliver glucagon. It backs off on those targets automatically so that it becomes less aggressive and it behaves like the single hormone system. That is, after all, how our single hormone system was born, not as a standalone product initially, but as a backup for bi-hormonal. We hadn't contemplated a single hormone system from the beginning. But when we saw how valuable and the value proposition the single hormone system had to offer, we pursued that in parallel with moving the much longer and more costly bi-hormonal project forward, financially costly. So that we had to explore different targets in order to understand what are the safe targets and the right targets for bi-hormonal, what are the safe targets and the best targets for insulin only, and allow one to move one to the other if the bi-hormonal system degenerates into the single hormone configuration automatically. So we mapped that space out. And what we found, as you might expect, is when you lower the glucose target in a large cohort of people, right? And by large, I mean 20, 40 people. It doesn't be that large, but on average, with the single hormone system, if you take the exact same algorithm and you set it at a fixed target, you'll get some average glucose and a certain amount of hypoglycemia. If you lower that target, the average glucose typically goes down, and the hypoglycemia usually goes up. Not surprisingly, you've lowered the target. And if it doesn't go up, it's usually masked because those people ended up having to take more oral carbs to treat the lows. If you lower the target further still, the same trend. Their mean glucose goes down further, time in range goes up, but they see even more hypo and even more carbs required to treat lows. With the bi-hormonal system, what we saw as we lowered the target is the mean glucose continues to improve, time in range continues to go up as you lower the target. The hypoglycemia remains the same low level as it is at any of the targets, but the amount of glucagon the device uses increases consistently with each lowering of the target. So you use a little bit more glucagon each time. So if you lower the target 10 mg per deciliter, we saw a 50% increase in glucagon. They're still tiny doses compared to what we're used to clinically, a rescue dose, but it does go up. It's kind of in a factor of 2 with each lowering of the target. We saw a little increase in the glucagon, but we didn't see a change in hypo, which shows you the glucagon is really doing its job of taking care of the hypoglycemia no matter the target. I'm so getting behind because I didn't answer your most recent question. Didn't you say you were looking at yourself, right? I'm taking notes over here, right?
What was my question? What was my question?
The question was, I'm a weird bird. You know, I'm a looper. I'm somebody who is, you know, getting really good time in range. It's not.
I'm not a looper. I'm using an app called Trio, formerly IAPS, another open source app.
Got it. Okay, but it is open source.
It is open source.
And there's a lot of parameters that you needed to dial in and figure out for yourself and get to a steady state. And you are certainly very knowledgeable about what those parameters do, how to adjust them should you get sick or have a change in level of activity or stress, right? So you are the diabetes intelligentsia. You are an Uber user, as we call it, right? And so as a consequence, you are expecting to be engaged. And you're actually, many people in your, you know, with your kind of skill sets and engagement level would be frustrated if you weren't allowed to adjust all these knobs, right? You have a lot of knobs you can turn on these systems, and you've turned a lot of knobs to get to where you are, and you're willing to continue to do that as your insulin needs change, which they inevitably will over the course of time. So the iLet is on the other end of the spectrum of your system. So we don't allow you to touch any knobs except the glucose target. There's 3 targets you can choose from, and most people just choose the usual target in the middle. But you can have 2 different targets in a given day, and that's it. There aren't all these knobs, and there's no changing of all these knobs at follow-on care, changing carb sources, correction factors, temporary basal rates, regular basal rates, right? You can't do that with the iLet. So we do find people like yourself are folks who oftentimes the iLet provokes anxiety in them when they use it. And very often the iLet can produce glucose results that are not too dissimilar from what you're able to achieve. But it does so at much less engagement on your part, which doesn't always translate into a reduction in burden for you, because you have this other burden, which is anxiety. And so he's like, I'm not going to sit here at 220 mg per deciliter postprandial. I'd get in there, I'd swoop in and give myself a correction. Can't do that with the iLet. And people do then consequently misuse the iLet on occasion and use the meal announcement, announce a meal that didn't happen, but then you just taught the iLet something that wasn't real. And with the iLet, unlike a hybrid closed-loop system, if you do that, you're literally teaching the iLet something that's wrong. With a hybrid closed-loop system, if you announce a false meal, it doesn't learn from that. It just gives you some insulin. With the iLet, it learns that I didn't need to add any additional insulin after you gave that meal announcement because it was a fake meal, and it makes the correction algorithm less aggressive and the meal announcement potentially less aggressive. So tomorrow, you just undermined what you were trying to do. Yeah, you got some insulin up front right away, right? And that you solved that problem for the moment, but you made a bigger problem for yourself tomorrow and the day after. So we do see that kind of maladaptive behavior, we call it. And it's really coming from people who are very engaged with their diabetes therapy. And they find that there's a lot of anxiety that comes with not being able to go in and adjust their therapy to titrate insulin anymore. So it is, like you say, a small group of people. And many of those people can push through and back off and let the iLet do its thing. And if you let the iLet do its thing, you're going to have the best likelihood of success. And some people can't. So we want people to know that you have 90 days to test this out, right? So we let you try the iLet and find out who you are. You don't know if you're someone who can push through, right? until you try the iLet. And you may be able to give up all of that, and you might not be able to. And the only way to find out is to run the experiment and use the iLet. So that's why we want people to be open-minded about it, but also understand you might not be able to cross that bridge, and then you can go back to your old therapy.
You've mentioned clinical trials a few times with the bi-hormonal pump. People have used this. Like, where are you with, I guess, what clinical trials have kind of happened?
Yeah.
And have people actually worn this pump or a rendition of it, like running the algorithm? Where's that at?
Yeah. So the very first human trials we did with the bi-hormonal system were on a system that ran on a laptop. Okay. And it was tested in a clinical research center. So you would not recognize it as the iLet, right? So we started with something like that, and we ended up with something like this, right? This little tiny iLet, right? But we started with this investigational device, and we were in a clinical research setting, so they were literally in a hospital bed for a couple of days, hooked up to this thing, and they could walk up and down the floor by pushing an IV pole that had the laptop on it, along with a bunch of other medical devices. So we were monitoring their glucose levels, we were measuring their plasma insulin levels and their glucagon levels in the blood plasma. So those experiments went on for about 4 years, and they were small groups of 20 people, 10 or 20 people that did this for a couple of days.
And when was that?
2008 to 2012. Okay. Quite a while. Okay. We've been at this for a long time. By 2013, we were able to port this system over to a iPhone and a Tandem insulin pump. So Tandem got FDA clearance in November of 2011, and we were in desperate need for some kind of pumping platform that we could use to take people out of the clinical research center setting and into a home use or outpatient setting. And it wasn't until Tandem came along, had a pump that had a Bluetooth radio in it, that we could actually even contemplate getting out. So we had some candidates along the way, and for one reason or another, they never worked. But the T-Slim pump hits the market in 2012. They get FDA clearance in 2011, and I start working with Sean Saint, who at the time was an engineer at Tandem. And he approached me at an ADA conference, and I took his name or his card. And in 4 months, 5 months later, I called him up when the announcement came out that they got FDA clearance. I said, let's get to work. And then he surprised me with even better news than I had known, which is we have a Bluetooth radio hiding in the T-Slim pump. And he had some folks I could work with at Sweet Spot Diabetes who he knew that could help us build the hardware platform. And so we began working throughout the calendar year 2012 on a system that was pretty kludgy, right? We called it the brick because it was about the size of a brick, not quite so heavy, but it was about that size. And it had an iPhone 4S on one side. So those could talk to each other, the T-Slim pump and the iPhone 4S. So we began working with Tandem, working with Dexcom, because they had just gotten the G4 out, and with Sweet Spot to build this system. And then Egret Systems was working with Dexcom as well to help us with this. And so we built this little brick in just a few months. And essentially, the transmitter on the G4 Dexcom talked to the receiver on the back of the brick, which was hardwired into the phone on the other side of the brick. The phone had the algorithm running on it and our own little custom user interface, little app that we made at BU. Back then, that was kind of in the early days of app development, but we had a guy who worked in IT at Boston University. And for about $110,000 of money that was donated to me by, family members of people who had kids with type 1, we built this system, presented it to the FDA with the help of Tandem and Dexcom using their master files. And we got FDA approval to begin testing that system in November of 2012 and began our first home use clinical trial in February of 2013. As far as we understand it, this was the very first outpatient study of any automated insulin delivery system in a home use or outpatient setting by an academic or any other. Very soon, within a few months of that, some other academic groups got FDA approval. We were the first to really test a home use system like this. And it was fully bi-hormonal. It was, it was not like an incremental step toward automation. This thing was fully automated, single hormone on one side, glucagon, second hormone on the other. We used two separate Tandem pumps. One delivered insulin and the other was repurposed to deliver glucagon. So you carried two pumps, two infusion sets. You carried the brick. This was inelegant, mind you, but it gave really beautiful glucose control. So we started with a hotel study and a camp study in 2013. We did a second camp study in little kids in 2014. We started doing multi-center home use studies where people lived at home instead of in the hotel, could walk about for 2 weeks with the device, 11 days with the device. And then we did study after study. And then we started doing single hormone studies around 2015. So we did a bunch of bi-hormonal studies all the way up to 2015. Then we started using the same system, but taking the glucagon pump away, and did single hormone insulin only studies in parallel with the bi-hormonal studies. And we even did a glucagon only study in people with type 1, where they managed their insulin, and we took away the insulin T-Slim pump and used the glucagon T-Slim pump. And that was to look at people who were hypoglycemic unaware, to understand, could you use just a glucagon only therapy in not necessarily people with type 1, but people who had congenital hyperinsulinism, for example, and they're secreting too much insulin. Can we just give glucagon? So we did that study as well. But we tested it first in people with type 1 who were hypoglycemic unaware. So they didn't know they were hypoglycemic. And it worked so well to reduce hypoglycemia. It was impressive.
Wow.
We reduced hypoglycemia overnight in that one study 19-fold. 19-fold. 24/7, we reduced it 4.5-fold. Just by giving them glucagon without adjusting their insulin therapy, let them just do their own. So it's really impressive what glucagon can do to reduce hypo, even if you don't have control of their insulin therapy. So we did all these studies, and then around 2013, 2014, while we're using the brick, we start building in my lab the iLet, which my wife named in honor of the islets of Langerhans, as a particular kind of bionic pancreas, which is kind of the brand name, is what we were thinking for the bionic pancreas. And we made a first version of it, which we're fully embarrassed by, thoroughly embarrassed by that. I mean, if you saw what that first generation looked like, it's so funny. Right? I mean, you could literally cut it. It had sharp edges. You could cut your finger on it by accident. I mean, it was so funny, but we got this thing done. It didn't much work very well. But we quickly abandoned it and moved to the Gen 2 iLet, which actually worked. And we were able to test it in pig studies. And we were developing our own infusion set at the time, a dual cannula infusion set for 2 hormones. And then I learned about the cartridge that is available in Europe. What they call, Novo Nordisk calls the pump cart. It has a 1.8 ml capacity, and they sell Novo Rapid, which is what we call Novolog here in the US, in Europe. And there are a couple of pumps in Europe that use that. I loved that pumping format, so we rebuilt the iLet to a smaller format, and that was our 3rd generation iLet. And the one that we ultimately commercialized was the 4th gen product, which is even smaller than the Gen 3, but uses that same smaller cartridge. Before that, we were using a 3 ml glass cartridge. So the cool thing is that Novo Nordisk got interested in our iLet, our Gen 3 iLet, and they said, we want to support a portion of the pivotal trial with a pre-filled cartridge with Fiasp, because Fiasp had just gotten FDA approved in adults. So they added some millions of dollars to the pivotal trial to help us add another cohort of adults using the pre-filled Fiasp cartridge in the iLet. So we have a patient fillable cartridge for Humalog and Novolog, and one that looks almost identical to it that's pre-filled in a little blister package available in the US for Fiasp, which is cool. But that was how the sort of progression of the iLets happened, beginning in 2013 or 14, all the way through to the Gen 4 iLet, which really was kind of ready for testing in human trials in 2020, late 2020. We used the Gen 3 iLet in human trials, and that was the first, really and only iLet we ever tested in a bi-hormonal configuration in adults with type 1. And we did that study in 2019. So it wasn't the T-Slim and Dexcom G4 brick. It was the actual 3rd generation iLet with 2 chambers. Dasi glucagon made by Zealand Pharma was in one chamber, 1 ml cartridge. And then we had the 1.8 ml glass cartridge for insulin on the other side. And we did do a home use study in adults, 10 adults with the Gen 3 iLet.
Thank you for all of that. That was so fascinating. And like I said, I'm so new to this. I feel like I'm on board now. I understand where you've been, where you're going. So yep. That was awesome. And I'm excited for people to hear that. Let's get into kind of what it looks like wearing this, or what it will look like. It's 2 hormones. And you mentioned that you started work on a dual hormone infusion set.
Yes.
So what does it look like wearing a device like this? And how does that infusion set differ from infusion sets, I guess, people are used to wearing? Right.
So let's start at the device level. This device was designed to have a capacity of 2 cartridges. So if you look here, I think you can see
the iLet that is out now.
Yeah. So the iLet that's out on the market now, the single hormone, there's 1 chamber right here. Right. But right here is accommodation for the 2nd chamber. Right? And that's where glucagon would go. So we would not have to make this format any bigger than this credit card size device. Still 15 millimeters in thickness, still the size of a credit card for a 2-hormone system. This is a pretty compact device. What are people using right now?
Yeah, that's pretty crazy because considering other pumps on the market are the same size and only have 1 hormone, that's a pretty compact size. It's
a pretty good size. We worked really hard to reduce it. And it's also a modern device. You know, I mean, it's got a capacitive touch screen. You know, it has touch, it has swipe capabilities as well. So it's a very modern system in that regard. It wasn't made 10 or 12 or 15 years ago. It was developed in 2018, 2019. So it is certainly a modern look and feel. It looks and feels like a smartphone in terms of the user interface being iconified, not all these menus like you saw on old non-smart cellular flip phones. So it's a modern device in that respect, but it also is a small format to handle 2 chambers and 2 motors and 2 drivetrains, right? So then what does it look like downstream of the device? We have 2 separate tubes that come out, right? One tube would come out of this chamber, one comes out of that chamber. Just like the Gen 3 iLet we tested in the clinical trial in 19, it was just a little bit bigger format, but it was the same idea. So 2 tubes come out. Now, and it uses the same, you know, Dexcom sensor as what we've been using in that bi-hormonal system to talk to the Gen 3 iLet and also, of course, the Gen 4 iLet, G4, G6, and G7 Dexcom now instead of G4 and G5 in the old days. But what we have done in all of our pre-pivotal trials and what we will do in the pivotal trial for the bi-hormonal system that's yet to be tested in the pivotal trial, the larger study, longer duration, larger study, is we use 2 separate infusion sets for the time being. So they're just insulin infusion sets like you're familiar with, Teflon sets or steel sets, but they are different. We don't use the exact same infusion set. So we'll use like the contact detach for one, a Teflon set maybe, and we might use a inset 1 or an inset 2 for the other. So you can't cross channel. If you disconnect to shower or swim, you can't put the insulin on the glucagon side and vice versa. They just won't connect. So we prevent cross channeling that way. And we also prevent cross channeling of the cartridge connectors over here, because that's a mistake we can't accept. So that right now it's just 2 tubes, 2 infusion sets. Our vision, and the pivotal trial, that's the way it will look. Our vision for the future, of course, is to make that more elegant on the body-worn side so that you could have an infusion set that would deliver both insulin and glucagon close to one another. We found that we can deliver within a centimeter of one another with no problem. There's no reason why we shouldn't be able to infuse even closer than that. So imagine 2 little cannulas, one way or another, under the skin. Importantly, it would look like a single infusion set, a single base, you know, adhesive base, and you would change that on a regular frequency. So maybe you change the infusion set on your skin with both cannulas every 3 days. But it's important to recognize that the insulin cartridge and the glucagon cartridge do not expire at the same time. One's got 1 ml, and for the concentrated insulins we've been using in the past, about 4 or 5 mg per ml, milligrams per ml, we can usually get about a 7-day supply in a little tiny 1 ml cartridge, even smaller than insulin cartridges you see in insulin pumps. So we can get a cartridge that's about half the size or a third the size of insulin cartridges in devices today. So it's really small diameter, short little 42 millimeter cartridge, and that can be like a week's supply in the average person. So our insulin cartridge we might change on average every 3 days. It's indicated for use for 3 days. But you could change that out every 3 days, and the glucagon cartridges, our goal is to be able to change that out once a week. So they have to be on different schedules. The tubing and the cartridge should be changed together, so we have to keep those separated. But there's no reason they need to be separated once they get to the infusion set. So you might change the infusion set once every 3 days and the insulin and glucagon cartridge on their own separate schedules. Does that make sense?
Yeah, that makes total sense. And also, it seems like the industry is moving towards 7-day infusion sets. Is that on the roadmap eventually? So you're changing out infusion set, glucagon, insulin every week?
Yeah. So first of all, the tubing is we ask you to change the tubing with the cartridge, but if the infusion set needs to be changed because it fails prematurely or you're suspicious of it, change it. But you have to change the cartridge and the tubing with that. So we separate the tubing and the cartridge as something that's changed together from the changing of the headset on your body, right? So we like to do that at the same time. So I would say the jury is still out on these 7-day infusion sets on the body.
Yeah.
The tubing, I have no problem with them lasting 7 days, right? I think that's something we'll all move toward, the industry will move toward. But infusion sets lasting more than 7 days, what does that mean? It's not like a sensor. A sensor doesn't have the kind of physical stress on it with a tube attached to it or a pod attached to it that degrades that adhesive, that can compromise the adhesive. You're pulling and tugging on it with your clothing as you move, whether you know it or not, in a way that these low-profile CGMs aren't nearly as victim to. And so as the adhesive fails under an infusion set, that's a pressurized system, right? With a CGM, there's a lot more latitude, forgiveness, if the adhesive starts to break down after 10 days or 14 days. Not entirely. Sometimes you start seeing funny numbers, right? And then you suspect that the adhesive's failed or whatever. But with the infusion sets, you can start to have what's called retrograde flow. And if that adhesive is not really well bonded to the skin, it can flow up along the cannula and leak out onto your surface, and you're not getting your insulin or your glucagon anymore. So making adhesives last longer, a lot of people with type 1 can't deal with that. They have skin breakdown, and adhesives, they can develop rashes. So I would say the jury's very much out on 7-day infusion sets. Even if they have indications for use for them, they might not, on average, last that long. And you might have more people having more infusion set problems from a 7-day set versus a 3-day set. So we'll see. But we do see the infusion set as something that could potentially be nearly as small on your body as a single cannula. And then think about what you're talking about. You've got an iLet, right, like we have now, or a T-Slim pump, or a any of these pumping platforms that are out there, Medtronic systems, right, that have instead of one tube, 2 tubes that you could tie together, right? You could just zip them together, and then one infusion set on your body with 2 hormone capability and 1 sensor. So your body real estate isn't changing here in a meaningful way with a bi-hormonal system versus a single hormone system.
So are you saying that the set that goes on your skin could theoretically be one piece that has 2 like lines that kind of go in different directions, essentially?
Exactly.
Okay.
That's something that we would like to see ultimately develop and be out there for a commercial product. But for the pivotal trial, we wouldn't need to have all that work sorted out. And all of our pre-pivotal studies use 2 separate insulin infusion sets. So
pivotal trial, that's what the next step is before this can get to consumers?
Yes, that is a big gatekeeping item, right? And the pivotal trial for a bi-hormonal system is much bigger, and bigger cohort, and a much longer study than a single hormone trial. Single hormone trials of insulin, that is, are typically capped at three months. They just don't need to be longer than that. The FDA hasn't mandated anything longer than a 3-month trial. And we've seen in type 1 diabetes on the order of 100 to 150 people. We had 440 people in our trial. We enrolled a much larger study than the other studies that were done out there. And it was 3 months. But here we're talking about a few hundred more than our biggest study, the 440-person study potentially, but maybe at least in that ballpark of 400 or 500, and a year-long study, right? So at least 100 people are going to have to be on device for 12 months. And a bigger subset of that cohort, but not the full cohort, will have to be on it for at least 6 months, and the rest for at least 3 months. So it's a bigger commitment, much bigger commitment, and it's a new drug in the sense that, you could think of glucagon as having been around a long time, but there are different formulations of glucagon. There are glucagon analogs. There's stabilization of human glucagon, and they all are used right now for rescue, right? They're tested in the setting of a single large rescue dose, a therapeutic dose. Well, that's not the way we're delivering. We're delivering doses that are about 1%, 1 to 2% the size of a rescue dose. And we're delivering them throughout the day, and that's called a chronic exposure. And it's what I would describe as a microdose, right? It's much smaller than the doses given clinically right now. So that's never been tested in type 1 diabetes, using glucagon in these tiny little minute doses here and there throughout the day, only as needed, not basal, but as the device dictates the need is there, here and there throughout the day, but every single day. And that's called a chronic exposure study, or that requires a chronic exposure study, because that's a chronic exposure usage. And so the FDA does require a longer study, and to look at doing all kinds of tests. It requires a new drug application because that drug has not been used in a chronic way. So it's a much longer regulatory interaction too. It's not just a longer trial, but it's a longer regulatory action on the front end and on the back end. So this is a multiple year commitment. So we don't have timelines sorted out yet fully for when that study would start, when it would finish, how long it would take to submit, how long the FDA would need to review it before we could launch the product. But, you know, it's not tomorrow, right? It's not this year, right? And that's an important thing for people to understand, that this is a big commitment that Beta Bionics has to this project. It's the premier product as far as we're concerned that we're striving toward. And frankly, all of our investors are highly committed to it. This is something so many people are bought into, the value proposition, which is wonderful to see. And there's lots of support around the table for this, but it is something we're going to have to be patient with and expend a lot of effort and resources to get it there.
Yeah, and it represents a huge step, or what will be a huge step in the treatment of diabetes. Yeah. You know, you're the first to take the plunge, but you'll also unlock the door for treatment to evolve in so many different ways. So I'm hopeful that this can happen as quickly as possible. So, you know, there could be a new way of treating this and making the lives of people living with this disease just so much better. Speaking of the glucagon that needs to go through all of that, there's a new, you've teamed up with Xeris specifically for them to provide the glucagon component for the pump. So Xeris makes the Gvoke HypoPen, which is a life-saving device for when you have a hypo.
Right.
What's coming with this new partnership?
Good question. Yeah. So Gvoke is regular human glucagon. It's the actual human glucagon molecule that's been stabilized in a non-aqueous liquid. And that allows the glucagon molecule to be stable, just like insulin is today, in a vial for, you know, insulin stable, as you know, for a couple of years under refrigerated conditions and up to, I think, 28 days at room temperature. Well, this drug is actually at least that stable, if not more stable. So it's practical from a pumping standpoint. And it is the human glucagon molecule. Most of our bi-hormonal studies were done using the human glucagon molecule. The way we were able to do that without the Xeris glucagon initially was we just remixed it every day, because it's not stable in solution very long if you put it in water, which is the way the rescue kits work. So Xeris has come up with a way of stabilizing it with something called dimethyl sulfoxide, which is a non-aqueous liquid for the delivery vehicle. And that makes it stable. And that's how they deliver their rescue glucagon in the rescue pen. So what we've done is to work with them on a formulation that would be appropriate for pumping in a bi-hormonal system, very small doses and at a higher concentration, because we're using a tiny little cartridge that we've already designed for the bi-hormonal iLet. So that partnership is all about developing the formulation, dialing in on testing that needs to be done, right? It's called there's compatibility testing, biocompatibility testing that has to be done, testing with the iLet itself, in you know, dose accuracy studies and what's called in-use compatibility. And then there are other small clinical trials we would likely do up front with that device, with that drug in our device before starting the pivotal trial. So this partnership is really all about doing any preclinical work that needs to qualify the drug and the device for clinical trials, and then do those clinical trials together as a partnership. And then, you know, we have a royalty arrangement with them, as we mentioned in our press release about this. So this partnership extends, of course, beyond the trial into a commercial relationship. So Beta is going to be taking a very front seat role in developing the drug with Xeris and being responsible for that drug and for the regulatory process around it and supporting it after it's approved for use in this application, and commercializing it, essentially providing the drug with the device to patients. So it's a really long-term relationship that we've established. Now, we've worked with Xeris for many years in the past. Back in I think it was like 2013 or 2012 was when we started talking to Xeris. And we had done some studies with their drug outside of the bionic pancreas setting with it in mind to use in the bionic pancreas in the future. They focused on the rescue kit. We were working also with Zealand Pharma, and they make a analog of human glucagon, which doesn't use the actual glucagon molecule. And that has its own regulatory challenges separate from the human molecule. But they're just sort of different challenges you meet, whether you use an analog or use the human glucagon. So we were working with Zealand on this for a while too. The Xeris partnership is renewed. But it's a really different conversation than when we were academics. Beta Bionics didn't start till 2015. So the work that Stephen Russell and I do, our chief medical officer, did with Xeris back in the day was as academics. And all of it was around clinical trials of investigational product and investigational devices. And now we're talking about a much longer term commercial relationship, not just an R&D one.
Ed, thank you so much for coming on the show and giving me a lesson on kind of your path so far. It was so cool to hear about all the steps that you've already taken and all the companies you've worked and people you've worked with. It was a great view at where you've been, and I'm excited to see where you go. So thanks for coming on.
Yeah, I appreciate you having me.
So what do you think about the bi-hormonal pump? Would you use something like this? Do you mind having 2 infusion sets, even if they're maybe brought together and putting one? Would you do a tube pump? Let us know in the comments. If you haven't already, go check out that demo of the iLet I have on YouTube, as well as my interview with the CEO, if you want to hear more about their current pump that is out on the market. New episodes of this podcast release every Monday on YouTube and on all major podcast platforms. So follow wherever you want to listen. I'm Justin, and I'll see you next week.